Good evening, everyone. I'm Jackie Dominguez, the American Liver Foundation's National Senior Director of Engagement, along with my colleague, Ivory Allison, who is the National Manager of Outreach and Education. We're proud to welcome you to tonight's presentation. Thank you for joining us. It's my privilege to not only welcome you, but to introduce Dr. Stephen Fern of Specialists in Gastroenterology. Dr. Fern is a very active member of ALF's Local Medical Advisory Committee, and he's our 2020 Medical Honoree of the Year. His brief bio speaks to his clinical interests. You can see the bio on the screen. His clinical interest in liver diseases and his dedication to the liver wellness of your community. In addition to his busy practice, Dr. Fern is the champion of healthcare professional educational programming on behalf of ALF. He has accepted and certainly lived up to the challenge of identifying liver topics of interest, as well as inviting knowledgeable speakers to share their expertise. Thumbs up to him for recruiting Dr. Bruce Bacon. Dr. Fern will now formally introduce tonight's speaker. Not that he really needs an introduction, but it's always polite to do so. And serve as the moderator for the remainder of tonight's program. Dr. Fern?
Thank you, Jackie, for that real kind introduction. It certainly is my pleasure to introduce tonight's speaker. I'm always amazed when people say a person who needs no introduction, and of course Bruce is one of those people, but Bruce is more than just a speaker. Bruce has been our mentor and our friend and our colleague for a long period of time here in St. Louis. And so back in 2010, the American Association of Study of Liver Disease honored him with the Distinguished Service Award for his contributions to the development of hepatology. And we could be here all night listing all of his accolades and his achievements and his publications and his presentations, but mostly Bruce is our mentor and our colleague and our friend, and it's someone who's sorely going to be missed in the community. So I would like to introduce Bruce for tonight's lecture. A little housekeeping first, that we here at the American Liver Foundation want to really impress upon you that the COVID-19 pandemic has really affected our means of getting education. So it's always beneficial to work through the virtual network. A little housekeeping about tonight. We're going to ask that if you do have a question, up in the top right, on my screen at least, there's a little chat circle. If you have any questions, please go ahead and ask your questions there, and we will answer the questions at the evening. Dr. Bacon has said he'd stay a little bit late if we need to in order to answer the questions. And please mute your device to minimize any background noise, as we all have. So really, without further ado, I want to introduce our mentor and our teacher and our colleague, and like I say, someone who's going to be missed immensely. Dr. Bacon, speaking about one of his most favorite topics, hereditary hemochromatosis. Bruce, up to you.
Okay, thank you so much, Steve, for your kind words of introduction. I'm delighted to have been working with all the good clinicians in the Metro St. Louis area for the last 30 years, and have just recently retired, actually, but I'm still around and going to be available for questions and all those kinds of good things. Tonight we're going to talk about hemochromatosis, which I've been involved with for quite a long time. And if we go to the next slide. Jackie on the slides. I have nothing to disclose for this presentation. Next slide. So a little history of hemochromatosis. It was, the first case was described in the literature in 1865 by a French pathologist named Toisier. 24 years later, von Recklinghausen, a German pathologist, coined the term hemochromatosis, thinking it was a pigment disorder affecting the blood. So hemochromatosis was his name for the disease. Dr. Sheldon was a primary care physician and wrote a monograph. It's about a 300-page book on everything that was known about hemochromatosis up to 1935. And he called it, he said it was due to an inherited defect in iron metabolism. And he did that without all the fancy techniques that we have available to us these days. In 1976, Marcel Simon noted that, or localized the defect in iron metabolism to the short arm of chromosome 6, but it was another 20 years before the gene was actually discovered. And the gene was discovered by a company called Mercator Genetics. And probably the most fun thing I did in my career was I worked with Mercator Genetics that year and got cases that had typical features of hemochromatosis. And those were the patients that formed the first 30 or so, and I'll talk about the paper in a little bit, but the first 30 or so people that were actually identified with the genetic abnormality. And from 1997 up to the present time, there have been discovery of several other proteins involved in iron homeostasis, and we'll talk about those a little bit as we go along. DMT1, ferroportin, transferrin receptor 2, hemojuvelin, and hepcidin. Next slide. So this is how we classify inherited iron overload syndromes. We have the group of hereditary hemochromatosis patients, and then they're divided between HFE-related and non-HFE-related, HFE being the abbreviation for hemochromatosis. And of the HFE-related individuals, there are those individuals who have both copies of the C282Y mutation. Then there are some, so those are what we call C282Y homozygotes. Whoops. And then there are C282Y 863D compound heterozygotes. And then there are other combinations as well that are minor. And then there's the non-HFE related. In other words, they don't have the genetic abnormality of of the hemochromatosis gene, but they have iron overload. And it's because they have abnormalities in other genes that code for proteins involved in iron homeostasis. And those are listed there as the non-HFE related. Next slide. So another further classification are the people that don't have anything related to typical HFE-linked hemochromatosis. And these are individuals shown here with a long list. I'm not going to go through it all, but various secondary iron overload, iron-loading anemias, parenteral iron overload, and associated with chronic liver disease. Next slide. So the genetics of hereditary hemochromatosis is pretty well summarized here. The discovery was in 1996. It allowed us to understand the physiology of cellular iron uptake, and much research has been done on that over the last 20 years. Improved the diagnosis of probands. Before we sort of guessed that these people were homozygous for hemochromatosis. Now we can do a genetic test and prove it. Made family screening better, it allowed for population screening, and it allowed us, who took care of patients with liver disease, to screen for hemochromatosis in those individuals. Next slide. So the paper that was published in Nature Genetics in 1996, I've highlighted some features of it just over in the next couple of slides. So it was 178 patients who had phenotypic hemochromatosis. And my job on the project was to be the clinician vetting for the reliability of, yes, this patient has phenotypic hemochromatosis. And you wouldn't include a patient who had a refractory anemia and had 100 units of blood transfused. They didn't qualify as a typical phenotypic hemochromatosis patient. But we had 178 patients from 32 sites across the country. And to say that they had phenotypic hemochromatosis, they had to have any two of these 4 points here. An hepatic iron index greater than 4,500 micrograms per gram. Normal is around 1,000 to 1,500. An hepatic iron index greater than 2. An increase in Pearl's Prussian blue stain on the pathology slides, or greater than 16 units of blood removed by therapeutic phlebotomy. So I think that would fit anybody's criteria for saying that they had phenotypic hemochromatosis. And then this is the schematic of the protein product of the mutated gene that was put out in that paper. And you can see the cis 282 to tyrosine, that's shorthand is C282Y, and that's where the principal mutation occurs. And that affects the folding of the alpha-3 loop and prevents the hemochromatosis gene from producing a protein that would do what HFE does, which we don't completely have that worked out yet, but eventually that will come. Next slide, please. So this study was the first column on the left-hand side was Feder et al. Feder was the first author on that paper. And you can see the 178 patients from the United States. And within 6 months, there were 1, 2, 3, 4, 5 additional papers from various places around the world that were investigators or clinicians and basic scientists had stored samples on their panels of hemochromatosis patients, and they looked to see if they got the same things that we got. So you see the C282Y, C282Y under genotype, and there's 148 of the 178 patients. So 83% of the patients that we thought had characteristic hemochromatosis indeed had genetic hemochromatosis. And the other sites from around the world, look at Beutler is the next one. We were 83%, he was 82%. That's about as right on as you can get. Joannelle, a French group, 91%. Jaswinskas, an Australian group, 100%. Now they had a requirement that all of their patients had to have a family member that had hemochromatosis. So obviously they had genetic hemochromatosis. So that's why they're up at 100%. And then an Italian group, Corella, had 64%. They included patients with alcoholic liver disease and secondary iron overload. So their numbers weren't quite as good. And then we looked at our series just of our own patients and came up with the 91%. So it all held together quite nicely. Next slide, please. So we now think that patients with hemochromatosis in a large numbers of series, almost 87% were C282Y homozygotes. So it's a very reliable genetic marker. Next slide. And this is just another way to look at it. This is the frequency of these mutations within the general population. So there's a 0.5% chance that Steve Fern would be a homozygote for hemochromatosis and have be a C282Y homozygote, where there's a 20% chance that he could be an H63D heterozygote. And those are we see the H63D patients quite a lot because 1 in 5 has a mutation, so it's pretty common. You look for it, you find it. Next slide, please. Okay, and this is from these discoveries came a genetic test a few years afterwards, and just as a single tube of blood. It's a PCR-based assay. It used to cost between $150 and $200. I don't know. I didn't check to see what it costs nowadays. And you get a C282Y result and an H63D result in all of them, in all patients tested. And some labs do an S65C, which is a minor mutation. Next slide. So the incidence of hereditary hemochromatosis, there's several different ways to look at it. This looks at incidence. Now it's said to be, like I said, one in 200 to 250 individuals, but you can increase your chances of having it be C282Y mutation by getting individuals of Northern European descent, because that's where the gene came from, that part of the world. 11% heterozygotes, estimated up to a million afflicted Americans, and 27 million heterozygotes. Next slide. So the requirements for diagnosis are pretty straightforward, and I think all clinicians that have had a little bit of exposure to the disease in their training or their clinical practice know these. The requirements, you got to have a little suspicion. You have to suspect the diagnosis. You may have serum iron studies that are abnormal done as a routine. I've had patients that iron studies were done looking for iron deficiency, and lo and behold, they had iron overload. So there's a lot of different reasons why tests get done. But if serum iron studies are abnormal, they should be investigated. Liver biopsy and hepatic iron index, we rarely do liver biopsy anymore these days. It is important to look for evidence of alcoholic liver disease, chronic viral hepatitis, and fatty liver disease in patients who have abnormal iron studies, and occasionally you'll find some patients with genetic abnormalities as well. You want to do the genetic test in those individuals. Next slide. Well, what are some typical symptoms? These are here: weakness, lethargy, fatigue, apathy, abdominal pain, weight loss, arthralgias. Those are very non-specific symptoms and makes it understandable the difficulty in making the diagnosis, or the improved ability of making the diagnosis with the genetic testing available. The next slide just looks at the next slide. Common physical findings: enlarged liver, cirrhosis, skin pigmentation. There's a characteristic arthropathy, which I'll show you in a minute. The next slide shows the increased pigmentation. This is one of our fellows on the bottom arm with the white coat rolled up, and a patient with hemochromatosis. It's hard to get this with the lighting that we have in exam rooms. You know, you can't pick up the somewhat bronzing of the skin, but once you've seen it, you'll never forget it. This gentleman looks like he has a little arthritis in his elbow as well. He looks a little bit swollen. So this was a typical patient. And then the next slide shows the characteristic joint space narrowing and damage in the second and third MCP joint. And you can see they're a little bit wider. That's a classic joint film for a set of joints, hand films with the joint abnormalities seen in hereditary hemochromatosis. Next slide. But as time has gone on, we've actually found that we find more patients without symptoms than we do with symptoms. And this is just a paper I wrote with one of our fellows years ago, back in the mid-90s, and we took about 35 patients that I was taking care of who had hemochromatosis, and just looked at their presentation, and three-quarters of them, 73% of them, didn't have any symptoms at all. They were just picked up by abnormal iron studies. And I would say that would be the way most patients are picked up nowadays. When they do have symptoms, they're the list of the same things that the other patients had. Next slide. So this looks at a number of different studies from 1980, 1985, 1991, and the paper I just showed you, 1997, and looks at the principal clinical features. And it goes, what's important to look at is in a series of patients that were presented in publication in 1980, cirrhosis was seen in 94% of them. You go all the way over to the right-hand side of the slide, and in 1997, just 17 years later, cirrhosis was only seen in 13% of the patients. So we see patients with much earlier disease nowadays than we did in the past, and that's a good thing. Next slide. This just shows the natural history and disease burden. So if you go to the left-hand side, where you've identified a patient with an abnormal HFE, and then go in a little bit a quarter of the way across the slide, and you see a raised SF. That's a raised serum ferritin plus or minus transferrin saturation. So they have some biochemical expression. And then you go in a little bit further, and if they have the disease a little longer, they have increased liver iron, and that can be seen as many as 50% of people, and then increased hepatic fibrosis in 25% of people, and then iron-related disease in the minority of patients on the far right. So next slide. How do we evaluate iron stores? Well, we do iron studies in the blood, serum iron, transferrin saturation, and ferritin. And routinely, we would do a liver biopsy in these patients, but we just rarely do a biopsy anymore. It's just not necessary. There are some non-invasive imaging modalities as well, CT and MR imaging, and still a research tool, magnetic susceptibility testing. And you can always look backwards and look at how much iron was taken off by phlebotomy, knowing that each unit of blood has about 250 milligrams of iron. And some examples are here. Next slide. Okay, these are the sort of a repeat of what I said. Let's skip this one and go to the next slide. So that was liver biopsy. Next slide. And here we go. So this is about a 30-year-old lady who was still having menstrual periods, and so was losing some body iron, but had this degree of iron, with iron being the blue staining in hepatocytes that you see in the liver tissue. The next slide shows a patient with much more iron, but still in a periportal to portal distribution, and very little, if any, iron in Kupffer cells. This is all in hepatocytes. Next slide. This is a very heavily iron-loaded individual. Again, keeping the periportal to portal, or the periportal to portal distribution, and still hepatocellular, as opposed to Kupffer cell deposition. And then the next slide is a patient with cirrhosis, and this is a cirrhotic nodule, again with the same distribution of iron. Next slide. This is a patient with what I would say is classic cirrhosis from hemochromatosis, except this is a patient who, once we got genetic testing, we tested him to see if he was a C282Y homozygote, and he wasn't. So this is a gentleman who had one of the other protein abnormalities that I've been following him for 25 years. His picture is in several textbooks of liver disease, and the chapter on hemochromatosis for what the classic biopsy looks like, except he's not classic. He didn't have it. And then the next slide just shows his liver at higher power and shows all the tremendous amount of iron that you can pack into an hepatocyte. And finally, the next slide, this just shows the micronodular cirrhosis that occurs in advanced hemochromatosis. So next slide. Well, how do we treat this disease? It's pretty low-tech treatment. We have high-tech molecular biology to make a diagnosis, but we got low-tech treatment. We do phlebotomy, which they've been doing since a long time. It clearly works, though. It improves survival. You need to prepare patients for a somewhat tedious run of this. Iron burden in men is generally greater than it is in women. And it's difficult to predict phlebotomy requirements. When Bruce Luxon was with us, Bruce has a PhD in mathematics, and we tried to look at all kinds of different ways to predict phlebotomy requirements from various iron studies and different findings on biopsy and that, and there's no way we could come up with anything accurate, even with a great mathematician working on the project. It is useful to remember, though, that each unit of blood has about 25 to 30 nanograms per ml of ferritin. So as you're depleting your iron stores, your ferritin goes down, and you can get a little bit of prediction about when you're going to get down to the bottom. Next slide. So what we do is weekly phlebotomy. we check a CBC or a hemoglobin hematocrit, make sure that they're not depleted. We haven't made them anemic before we do a phlebotomy. We aim for a ferritin between 50 and 100 nanograms per ml and a transferrin saturation of less than 50%. Next slide. And then it's important to remember maintenance phlebotomy. Once you've done your initial therapeutic phlebotomy, you've got to make sure that you maintain this, because you haven't done anything to change the pathophysiology of the disease. You've just treated the complication of it. So we aim for a ferritin less than 100, transferrin saturation less than 50%, to maintain that, with 1 unit of blood being taken off every 2 to 3 months. Most patients absorb a couple of milligrams per day, more than they need, so that's why you need to continue it every 2 to 3 months. But every now and then you'll find a patient who has no reaccumulation of iron, and it's not necessary to do maintenance phlebotomy. Nobody knows why that occurs, but it's been observed by many experts in iron metabolism. And this is just a nice graphic picture of the response to therapy. First, you see that the transferrin saturation along the top doesn't go down until right before people have gotten rid of most of their iron. But the ferritin has a reciprocal decrease to the cumulative phlebotomy. So the cumulative phlebotomies are from the lower left-hand side up to the top in green, and the serum ferritin starts in the upper left-hand side and goes down and is in the red. So you can remember that, and you can watch patients with an ability to predict a little bit of what's going on. Next slide. This just shows what happens with phlebotomy. This is a patient who had hepatitis C as well as hemochromatosis, and he had some portal expansion, you can see there. And this was his pre-treatment liver biopsy, and the next slide is his post-hemochromatosis treatment prior to hepatitis C treatment biopsy. So you can see how effective the phlebotomy is. You have a few specks of iron here or there in a Kupffer cell, but it's pretty effectively depleted. The next slide. This just shows all the results of therapy, and you reduce to normal the tissue iron stores, improved survival has been shown, people feel better, heart function's better, diabetes is better, abdominal pain is reduced, skin pigmentation is better, liver enzymes normalize, hepatic fibrosis sometimes reverses a little bit. There have been studies showing reduction in portal hypertension by an Italian group, but arthropathy doesn't get better and testicular atrophy doesn't get better. But most things do get better, so it's worth treating. Next slide. So these are getting into some older studies now, because we don't do these studies so much anymore. This is a survival curve from a large group of patients followed by a German group, published in 1985. And you can see that survival goes down, is reduced compared to the normal population in patients with hemochromatosis. And then the next slide. And this just shows whether they're cirrhotic or non-cirrhotic. You can see the cirrhotic patients do a little bit worse than the non-cirrhotic. No surprise there. That's what we would expect. The next slide. So it's always important to remember family screening, and we don't do HLA typing anymore. We do HFE testing, mutation analysis, and it's pretty effective. I'm reminded of one funny little experience that we had with I was seeing a patient for the second time, and he had been diagnosed. We had him worked up. We were ready to go forward, and I started to talk to him a little bit about family screening, and he had 3 kids with him and his wife that were listening to all this, and I said, well, we could, we don't so often like to stick needles in the arms of youngsters running around in the exam room, so we could just check your mutation, your gene testing, and your wife, and we could pretty much see if the gene is present in that group, and if we need to do anything further on any of the kids. And he looked at me out of the corner of his eye, and he dropped his head down a little bit. This is a tall guy, he's about 6'6", dropped his head down a little bit, had a kind of sheepish look go across his face. He says, "Well, Doc, it isn't going to be that easy." And this was, I think, third wife and 3 kids by 3 different wives, and it wasn't going to be that easy. So we ended up testing the kids as it came to it, and no harm, no foul. But you have to be prepared when you ask some of these questions for answers that maybe you weren't expecting, and then know how to get back on your feet. Next slide. So for analysis of risk in children, do the mutation analysis in the spouse or the other parent, and you might be able to avoid testing in children. Next slide. And this is an example of a pedigree of a HH family. The proband is identified by the arrow in the upper left of the pedigree. And this is a 62-year-old lady who is a C282I homozygote. I've seen her recently, probably within the last 6 months before I retired, and she was still doing well. She was effectively treated initially. Her husband was an H63D heterozygote. I saw all 3 of their children, and there were 2 compound heterozygotes and a C282Y heterozygote and an H63D heterozygote. And then we got the next generation as well. And sure enough, there were 2 compound heterozygotes there and an H63D homozygote. So there's quite a bit of valuable information that you can get if you can put the effort into getting these samples. It's hard because you have to sample a lot of people to get all of that, but it was useful information. Next slide. And then I'm going to go through briefly some general population studies. Right after the gene was identified, a number of groups that were involved in iron metabolism did testing to look at the frequency of these abnormalities in patients who had HFE mutations. Next slide. So this study from San Diego was first authored by Ernie Beutler, who is a hematologist at the Scripps Clinic. And they screened 41,000 adults in San Diego, really a big job. And they did this at a health clinic, and they did iron studies and genotype, and had a questionnaire. The next slide. These are the results that showed he had 152 C282I homozygotes and 616 compound heterozygotes. And that kind of fits with the numbers of predicted individuals who are homozygote or compound heterozygotes. 67% of the C282Y homozygotes had an elevated ferritin, but interestingly, there was no difference in any symptoms from the controls, and there was only 1 patient that had typical signs and symptoms of hemochromatosis. So this was the first of these studies to come out like this, and some people criticized. Didn't criticize the study, but said, see, you have this disease with these genetic abnormalities, but what difference does it make? They don't have any symptoms, and the majority of them don't have evidence of liver disease. They don't show that here, but that was not a feature of this group of patients. Next slide. And this just shows, looking at the data a little bit differently as well. This is from the same study, and you can see the untreated homozygotes are the solid dots, and you can see both in men and women with transferrin saturation and ferritin concentration. You can see the numbers are all over the place. There's some that are high. You know, in general, they're a little bit higher than normal for transferrin saturation and for ferritin concentration, but they're not uniformly all high. So you have to be suspicious when you're making these diagnoses. Next slide. So this is a number of studies. So the Beutler study was included here, but a number of other studies here that showed a prevalence of homozygotes. That's the point I'd like to make for you, was 1 in 240 of all these 2, 4, 6, or 7 studies pulled together. And the number of C282I homozygotes with a normal ferritin was 41%. So there's a lot of people that have the disease is about as common as we thought it was, about prevalence of homozygotes 1 in 50 about, or 1 in 240 if you take the average. But a lot of them don't express. And it's important to remember that. Okay, next slide. Now we're going to finish up with some of the other abnormal proteins. This slide has patients who are C282I homozygotes but didn't have iron overload, and it's supposed that there may be environmental factors which you can identify, but it's more likely that it's genetic factors. And probably when we ever get to the point of doing this, meaning we, the iron community of investigators, they'll take C282Y homozygotes and find those that have what you would or wouldn't expect in terms of iron studies, and try and see if you can find abnormalities in any of these other genetic, in these other genes. Next slide. So in patients with iron overload, about 10 to 15% are negative for C282Y. So there we suspect that there may be mutations in other genes. So ferroportin, transferrin receptor 2, hepcidin, hemojuvelin, and others has yet to be diagnosed or yet to be discovered. Next slide. So a little bit about ferroportin first. So in my practice, I followed about 300 patients with hemochromatosis over the years, accumulated those patients. I had 1 patient with ferroportin, I had 1 patient with hemojuvelin, I had no patients with transferrin receptor 2, and I had no patients with hepcidin deficiency. So despite an interest in iron and staying in the same place for a long time where you can accumulate these patients, these are rare birds. So ferroportin is on chromosome 2. It's an autosomal dominant as opposed to autosomal recessive, which all the other genetic abnormalities are. It has a cellular distribution of iron in reticuloendothelial cells. It's probably involved in what we have called in the past African iron overload. The pedigrees have been described. It's been studied. In fact, Antonello Pietrangelo, in the references down at the bottom, 1999, he had a paper describing ferroportin for the first time, and he's credited with the discovery of ferroportin. Next slide. And to understand ferroportin disease, you need to know a little bit about iron export. So enterocytes, I'm not sure what I was thinking of on this one though. Yeah, ferroportin is upregulated in iron deficiency, downregulated by hepcidin, and the export of iron is mediated by cell types in many places in the body, with enterocytes, macrophages, and hepatocytes. Next slide. I have one more on this. No, I don't. Okay, so transferrin receptor 2 is on chromosome 7. It's autosomal recessive. It has a parenchymal cell distribution. It looks quite a bit like hemochromatosis. The pedigrees have been described. It's rare as hen's teeth, though. Next slide. And it's highly expressed in hepatocytes. And some have suggested that it may be the protein that senses hepatocyte iron levels to result in control of absorption by way of hepcidin expression. And the knockout mouse was done here actually at St. Louis U with Dr. Fleming in pediatric neonatology. And that knockout mouse has a typical hemochromatosis phenotype. Next slide. This is about hepcidin. Hepcidin is found on chromosome 19. It's a 25. It's a peptide. It rarely can cause juvenile iron overload, or what we would call juvenile iron overload. It's autosomal recessive, parenchymal cell distribution, and thought to be the hormone involved in iron regulation. That's because it's synthesized in the liver, but its site of what it affects is absorption. So the next slide. Hepcidin is regulated then by iron status, by erythropoietic activity, although we don't do much with that, by inflammation and by oxygen content. Intestinal iron absorption varies inversely with liver hepcidin expression. So if you have increased iron absorption, you have less hepcidin expression. And that's the conundrum that occurs in hemochromatosis. You have a decreased level of hepcidin. You have hepcidin deficiency state, if you will, but you still have an increased amount of iron absorption. So yeah, I think that may be on this slide. Hepcidin decreases the functional activity of ferroportin by direct binding, causing internalization. In enterocytes, this results in a decrease in basolateral iron transfer and a decrease in iron absorption. In macrophages and hepatocytes, it leads to a decrease in iron export and thus an increase in stored iron. Next slide. So hepcidin expression is low in hemochromatosis. Think of hemochromatosis as a hepcidin deficiency state. So there's increased iron absorption, which is not what you would expect with that. That's what makes it different. And an increased saturation of circulating transferrin. And hepatocytes become loaded, presumably because iron uptake from the circulation exceeds ferroportin-mediated iron export. Next slide. The last one of these really rare causes, hemojuvelin chromosome 1 causes what is called juvenile iron overload, autosomal recessive, parenchymal cell distribution, pedigree described again. Next slide. And this is mutated a mutation is found in the majority of patients with juvenile iron overload, and that leads to decreased hepcidin expression in clinical hemochromatosis. The mechanisms are unknown. And then the next slide on the home stretch here. This is what happens with normal iron homeostasis. So dietary iron is reduced by a reductase in the gut, transported into enterocytes by divalent metal transporters, and released into the portal circulation by ferroportin, facilitated by hephaestin. And all that occurs in the small intestine. Next slide. And this just shows it diagrammatically, showing uptake of dietary iron at the luminal surface of the enterocyte, transported across the enterocyte, and taken up by hephaestin/ferroportin on the basolateral surface, and then transported to transferrin, or transferrin receptor, I guess. Next slide. So this is a part 2 in the orchestration here. This is macrophages obtain iron from phagocytosis of senescent or old dying erythrocytes and release iron into the circulation through ferroportin. Iron in the circulation is mostly bound to transferrin, with some in non-transferrin bound iron. Non-transferrin bound iron is very efficiently taken up by hepatocytes. And circulating transferrin bound iron interacts with both transferrin receptor 1 and transferrin receptor 2. The next slide. And the third, oh, I'm sorry. Yeah, and this just shows those areas schematically or in this nice drawings. Next slide. So hepcidin then, so again, this is in the normal situation. Hepcidin and hemojuvelin are highly expressed in the liver. circulating transferrin-bound iron interacts with transferrin receptor 2 on the hepatocyte membrane, increasing the expression of hepcidin. Hepcidin response, in turn, modulated by HFE and by hemojuvelin, and hepcidin is released from the hepatocyte into the circulation with downregulation of ferroportin-mediated release of iron from enterocytes, macrophages, and hepatocytes. Next slide. And then this is what's proposed occurs in hemochromatosis. So when HFE, hepcidin, hemojuvelin, or transferrin receptor 2 are mutated, there's a decrease in hepcidin production by hepatocytes. So you have this decreased hepcidin state, which leads to an increase in ferroportin-mediated transfer of iron from enterocytes, which leads to an increase in iron absorption, and out of macrophages, which leads to a decrease in macrophage iron. What do you see in hemochromatosis? You see increased iron in the face of increased iron absorption. You think you should have a negative feedback there, and you don't see much iron in macrophages, so it fits. So there is increased uptake and storage of iron in the liver. The mechanisms whereby HFE, transferrin receptor 2, and hemojuvelin regulate hepcidin are as yet unknown. And the next slide just shows all the pictures together that we've seen that. And then the last slide is a short summary. Just it says in 2016 was when I prepared this slide, I guess. So most patients with hemochromatosis don't need a liver biopsy. Only about 60% of C282I homozygous patients have phenotypic expression. And about 25% of C282Y homozygous men have signs or symptoms of hemochromatosis. So you can modulate your thoughts about caring for some of these patients with a little bit of this information. We don't need to do as many liver biopsies as we used to. And a lot of patients don't really have what we would expect them to have with the mutations that they have. They don't express in all patients. I'd be happy for questions. That's my last slide. I know we've gone through a lot of material.
Thanks, Bruce. Always a pleasure hearing you talk, and especially on this topic. Amazing topic. I want to let the audience know that if you do have any questions, up at the top right in my screen at least, there's a little chat button. Please go ahead and enter your questions in that chat. I have one question, Bruce. When you check family members for hemochromatosis, do you just check once and you're done, or do you do it over a specific period of time?
Well, the genetic test, I think once should be enough. Ferritin, from seeing ferritin in clinical gastroenterology and hepatology, it bounces all over the place. So if I had someone where it didn't make sense to me, if a ferritin was high and I was expecting it to be low, or if it was low and I was expecting it to be high, I'd repeat it. But the genetic test, I think, those are pretty robust, and they probably don't need to be repeated.
Very good. Any other questions from the audience? We're coming up to our 7 o'clock time frame. If you do have a question, go ahead and enter into the chat, please. We have a chat from our colleague, Dr. Kornblatt. Bruce, what's your take on the interplay between hyperferritinemia and NAFLD? And do you think there's any role for iron reduction in subjects without abnormal HFE alleles?
That's a great practical question, because you see it all the time. So as frequently as we see abnormal iron in patients with fatty liver disease, you'd expect there to be an enrichment in those iron regulatory proteins in those patients, but that doesn't seem to be the case. Certainly not to the degree that you see in patients with hemochromatosis. So you see some patients with abnormal iron studies, and I think they need to be treated. There is some data, I'm pretty sure, that Chris Codley had published on abnormalities in iron homeostasis in patients with fatty liver disease, and making a pitch for phlebotomy of the excess iron. And I would not be opposed to that at all. If you've got two diseases and you can't be sure which one is causing the major problems, I would deplete them of iron stores as well. What was the second part of the question, Steve? You're muted. Unmute. You are muted.
You answered it. Was any benefited iron reduction without abnormal HFE alleles in that population?
Yeah, I think if you have a this is a place where sometimes you want to do a liver biopsy. You've got a high ferritin, but if it's in fatty liver disease, it might just be high ferritin, but not increased iron stores. So you might want to do a biopsy in that situation.
How about in patients with alcoholic liver disease with elevated ferritins, which we see all the time? Should we check HFE alleles or just tell them to stop drinking and see if the iron levels come down?
I think the angle there is to tell them to stop drinking, see if the iron levels come down. If the iron levels come down, you probably don't have genetic disease, at least for that gene. And the problem is, obviously, not everybody that drinks too much that we tell to cut down their alcohol does it. So sometimes you can make your case stronger if you do a biopsy in that situation. It, number one, means you're serious about the problem. You're going to do something invasive. And number two, it gives you information that you may be able to go back and say, hey, look, you've got a lot of iron here. We got to get rid of that as well. It's a good thing we did that biopsy to find that out.
That may be a major problem in the universities of, because obviously out here in the community, when we tell our patients to stop drinking, they do all the time. So maybe it's just a university problem, but.
Our patients do everything.
Any other questions from the audience before we let everybody go? Well, I'm going to say, Bruce, once again, thanks for giving us a wonderful lecture. Thanks for all the years you've mentored us and taught us. It really is appreciated, and obviously amazing success and enjoyment in your retirement.
Thanks very much.
Yeah. And Jackie, I'm going to turn it over to you for any closing thoughts.
Thank you so much, Dr. Fern, and certainly we appreciate again that you took the time this evening to join us for this exceptional presentation. Dr. Bacon, thank you so much for joining us. Dr. Fern, thanks for putting on this amazing program, and be on the lookout for additional programs of this caliber in the future.
Thanks, everyone. Good night. Be safe, and someday we'll do this together face to face.
Right.
Have a great night, everyone.
Thank you. Good night.
Good night.